So now we'll talk about immune modulation in type 1 diabetes. I'm here with Chantal Mathieu from University of Leuven, Matthias from Herrath, a professor and expert on type 1 diabetes, and Olle Korsgren from University of Uppsala. So where is the field currently, and why haven't we cured diabetes yet?
Well, that's a question I, as a clinician, very often get from my patients with type 1 diabetes. And it's not because of lack of trying. There's a lot of research ongoing worldwide, very high-level research. And we are making progress. We are getting better insights into what is this disease that is type 1 diabetes. And what we've learned is that it's really a very complex disease, with not only what we thought a couple of years ago, the immune system just attacking the beta cell as a sitting duck and the beta cell dying. We've now also learned that the beta cell itself plays a very important role in its own destruction, sending out signals to the immune system and dying in a certain way. So it is a complex disease.
Is it one disease?
That's another question.
The diagnosis is made on just the clinical symptoms, and it wouldn't surprise as we gain more and more knowledge that we will be able to stratify these into multiple different diseases that end up with the same beta cell destruction, and then the same clinical symptoms will develop.
Yeah, certainly we need some form of stratification also for the trials, right? Because one thing that's slowing us down is that we have metabolic endpoints for the clinical trials, and they often take some time. And because also the heterogeneity in disease progression, pathology I'm not sure yet, but heterogeneity in disease progression that drives up the amount of patients you have to enroll for each arm, and then the trials become long, complex, and very costly, and that's of course not accelerating things. But Chantal mentioned it, we're making progress. It's
absolutely. But about the heterogeneity, again, for the clinicians, it's so obvious that a child who gets type 1 diabetes at 2 years of age is very different from the person getting it at 40 years of age. And as Matthias said, biomarkers that would allow us to better phenotype, characterize patients in order to get, if we get interesting tools to intervene, to give the right tools to the right patient, and also to design better trials. And so there are many efforts ongoing on finding better biomarkers and understanding this disease better.
In a way, it's an exciting time, because now we have these big consortia like IMI, Nodia, and so forth, like TrialNet, where everybody begins to work together. And I think for finding proper biomarkers and dealing with large cohorts of people, that's absolutely needed. That's not a single lab's or person's effort. And in a way, it's an exciting time, and an exciting time of progress.
And what is important is, if we want to beat this beast, if we want to prevent or cure this disease, we will all have to work together. Not only academics, but also industry. And as Matthias said, in initiatives like Inodia, supported by IMI, you have the funders, you have the academics, you have industry, and patients. Everybody working together, trying to get a better idea of how this disease is going, and how can we really do something. But I think one of the biggest challenge, we already said heterogeneity, biomarkers, but another big challenge to me is the fact that we have no access to the organ where everything is happening. And as, for instance, Olle has demonstrated, this is really very important, because a lot is happening in the pancreas.
And I would say also that the field is benefiting now of the technical development in parallel to the diabetes research. So imaging, biomarker search, everything like that is also very interesting period in time now. Development is really, really fast in those areas. And my hope for the very near future is that these technologies will give us tools to stratify people entering into clinical trial, but also to help us in designing good endpoints of our trials.
And of course, in respect to the pathology, it would be really nice, in a way, if one of these days we understand what causes this disease. And as Chantal and Olle already referred to, it's complicated. We just now, with access to the human organs, begin to understand that's an interplay between beta cells and the immune system, most likely. But there has to be also other factors, maybe environmental factors. We don't know them. We have struck empty, finding a virus that causes the disease. That was a popular hypothesis over many years. Then there have been these hygiene hypotheses. But we also have struck empty to identify a single culprit. But we need to look more, because there's this gnawing feeling. I think you have this too, that we might overlook something. You have brought forth interesting hypotheses about the pathogenesis. I think the field needs this to be a little bit shaken up to make us think again. And maybe if we have the cure, if we have the cause, then finding a cure for the disease will become easier, right?
And I think also that the type 1 diabetes is an orphan disease in the way that it's one of the most severe chronic disease a young person can be affected by. But in terms of funding, attention in the general public, in our society, it's much, much inferior when compared to cancer or other diseases that also affect young people. So I think also we need to get an increased awareness of how promising the research are, and that we actually are going, hopefully, to be able to treat our patients much, much better in the very near future, and perhaps also cure the disease in some people affected.
Interesting trials are running. I mean, we are doing trials, but as Matthias said, there's always this challenge of getting homogeneous group of patients to really be able to make solid conclusions and refute certain therapies. I think we've made some mistakes in the past, like with the anti-CD3, where we took very heterogeneous populations, took very strange endpoints. So trials that are running now are typically trying to combine certain therapies, therapies that might protect the beta cell together with immune modulation, for instance, and we try to get better, more solid endpoints that make more sense in preventing or arresting a disease like type 1 diabetes. It's absurd that you would have as an endpoint hemoglobin A1C in these days where you have analogs, pumps, and what have you. You know, this is trying to arrest an autoimmune destruction of the beta cell. So we need to have markers of beta cell function or beta cell mass that are really the endpoints. And so a lot of effort is put into also convince regulators, for instance, to accept these endpoints in a disease like type 1 diabetes, for instance, C-peptide. And that's not obvious. It's very different from type 2 diabetes.
And also one big problem in doing clinical trials is that by tradition, the regulatory bodies in our countries often only accept one investigational drug to be tested. Exactly. And what Chantal is talking about is that we take-home message from the entire field now is that we have to combine different treatment options.
Yeah. And where do you time the trials? Like at what stage of the disease or the patient?
That's a very crucial question and relates a little bit to the issue, what do patients really need? And how much are they willing, in a sense, to pay or take in terms of side effects for that? That's one way why we need these combinations, maybe to have more synergies with two different therapies, but spread the side effects so the therapy becomes more palatable for the patients. And we can also, if we're talking about prevention, then of course the benefit for the patient could be greater, because you could stave off the disease for several years, and there's little argument that of course is very strong benefit, especially if you're talking recent onset trials. There's now pumps, there's better means to control glycemia, there's sensors, so the incentive for the patient to do something drastic becomes lower, and the bar for the therapy in terms of having no side effects and achieving lots becomes ever higher. It's climbing sort of in front of us. And
but I would also like to salute all the patients participating in different trials.
I know.
There is this altruistic attitude in the community. So we can ask patients to participate in a trial that just would generate knowledge. they would not benefit from being part of the trial, but they are willing to participate just to help us to help other people affected, even if they, as individual, cannot.
Exactly, and again also, you know, these patients are so supportive of all our initiatives, and they help us to better understand this heterogeneity, to develop better biomarkers. Another challenge is that very often we are dealing with children. So, and also the first degree relatives of these children are children. And so they are so motivated to give their blood and other samples over and over again. So indeed, it is very important. But then again, it comes to Matthias's comment about the bar. We are treating children. So side effects, safety, it is really a very big discussion when you think on the one hand we're trying to arrest autoimmune destruction of the beta cell or improve the beta cell function, but on the other hand we are treating young people for a long period of time, and you know, finding the right balance between efficacy and safety and acceptance of side effects is what makes this also difficult.
Yep. And that translates to the timelines, because often you have to test something in adults first, if it can be done, and I think that's fair. So that takes longer before you can move it down the line in age to treat children. And so the overall tries timelines to finding a new drug candidate and then having a phase 1 safety and a phase 2, maybe ideally combination. That's like 5 years, maybe if you're really lucky for the new candidate, 2 years for the safety and some biomarkers maybe. Then another trial for phase 2 with more biomarkers. So you're already a decade out, and you're in the best case done with a phase 2 trial, whether you have to then take a step back and say, does this qualify for phase 3? It's not so fast for the right reasons. I mean, because of children being affected and because of safety. But that was your initial question, and of course the question from all the patients.
Well, thank you very much for participating in this discussion.
Thank you.
Thank you.